Drug resistance in cancer. Drug resistance is a major challenge in cancer treatment, significantly reducing the efficacy of chemotherapy, targeted therapy, and immunotherapy. Resistance can be classified as intrinsic, pre-existing in cancer cells before treatment, or acquired, develops after initial treatment. Mechanisms of drug resistance. 1. Pharmacokinetic and pharmacodynamic resistance. Altered drug absorption and distribution. Poor absorption, rapid metabolism, or enhanced drug elimination can lower effective drug concentrations. Tumor microenvironment. Abnormal vasculature, hypoxia, and acidic pH reduce drug delivery to tumor cells. Drug efflux. Overexpression of efflux pumps like P-glycoprotein, PGP, and multidrug resistance associated proteins, MRP, actively transport drugs out of cells, reducing intracellular drug concentrations. 3. Drug inactivation. Cancer cells may upregulate enzymes like glutathione S transferases, GSTs, which detoxify chemotherapeutic agents, reducing their effectiveness. 4. Altered drug targets. Target mutations. Mutations in drug targets reduce drug binding, e.g. mutations in EGFR or BCR-ABL in targeted therapy. Target expression. Cancer cells may downregulate the target protein, e.g. loss of estrogen receptors in hormone therapy-resistant breast cancer. 5. DNA damage repair. Enhanced DNA repair mechanisms, such as upregulation of homologous recombination repair, HRR, or non-homologous end joining, NHEJ, counteract the cytotoxic effects of DNA-damaging agents. 6. Evasion of apoptosis. Cancer cells often develop resistance by evading programmed cell death through overexpression of anti-apoptotic proteins like BCL2, loss of pro-apoptotic factors like P53. 7. Cancer stem cells, CSCs. CSCs exhibit intrinsic resistance due to quiescence or slow cell division, overexpression of drug efflux pumps, high DNA repair capacity. 8. Epigenetic modifications. Changes in DNA methylation or histone modifications can silence tumor suppressor genes or activate oncogenes, conferring resistance. 9. Phenotypic plasticity. Epithelial mesenchymal transition, EMT, enables cancer cells to gain a more aggressive and resistant phenotype. 10. Immune evasion. Cancer cells may develop mechanisms to evade immune detection, such as upregulation of immune checkpoint molecules, e.g. PD-L1, recruitment of immunosuppressive cells like regulatory T cells, TREGs. Types of drug resistance. 1. Single drug resistance, resistance to a specific drug due to mutation or other mechanisms. TAP 2. Multi-drug resistance, simultaneous resistance to multiple structurally unrelated drugs, often mediated by pumps like PGP. 3. Cross-resistance, resistance to drugs with similar mechanisms of action, even if the patient has not been exposed to all of them. Clinical implications of drug resistance. 1. Decreased survival. Drug resistance leads to disease progression and poorer outcomes. 2. Relapse and metastasis. Resistant cancer cells can repopulate and metastasize, making treatment more difficult. 3. Increased toxicity. Higher doses of drugs required to overcome resistance increase the risk of side effects. And strategies to overcome drug resistance. 1. Combination therapy, combining drugs with different mechanisms of action to reduce the likelihood of resistance development. 2. Inhibition of drug efflux. Use of efflux pump inhibitors, e.g. verapamil, to increase intracellular drug concentrations. 3. Targeting cancer stem cells, developing therapies to eliminate CSCs, such as inhibitors of CSC-specific pathways like Notch, WENT, or Hedgehog. 4. Epigenetic therapies, using DNA methyltransferase inhibitors, e.g. azacitidine, or histone deacetylase inhibitors, e.g. vorinostat, to reverse resistance-associated epigenetic changes. 5. Immune-based approaches, immune checkpoint inhibitors, e.g. anti-PD-1, anti-CTLA-4 antibodies, CAR T-cell therapy targeting resistant cancer cells. 6. Nanotechnology, nanoparticle-based drug delivery systems to enhance targeted drug delivery and bypass resistance mechanisms. 7. Gene editing, use of CRISPR-Cas9 to reverse resistance-causing mutations. 8. Personalized medicine, identifying patient-specific resistance mechanisms and tailoring therapies accordingly, e.g. using next-generation sequencing to detect mutations. Future perspectives. 1. Biomarker development, identifying predictive biomarkers to monitor resistance development. 2. Artificial intelligence, AI, using AI to analyze large data sets and predict resistance patterns. 3. Tumor microenvironment targeting, developing therapies to normalize the tumor microenvironment. 4. Adaptive therapy, using lower drug doses to manage resistance dynamically. Conclusion. Drug resistance remains a significant obstacle in cancer management. Understanding its mechanisms and developing innovative strategies to counteract resistance are crucial for improving patient outcomes. Personalized, multimodal approaches integrating traditional therapies, targeted drugs, immunotherapy, and novel technologies hold promise in overcoming this challenge.